Okay, welcome to this month's webinar. It's a little different from previous ones. Basically, we're going to look at one slide in addition to the quiz slides, but in total educational slides, there is only one, and I'll be talking around it. The topic today is point pain of the shoulder and avoiding getting caught up in too much history and then relying on some sensitivity tests and then specificity tests to determine what the actual pathology is. So, having said that, it shouldn't take very long. There's nothing to read here. There's no supplementary materials, no notes. It's all just straight to camera. So, let's move along to the quiz first. Let's see what you can remember about this. There are two pictures, 4 eyes, and 2 pathologies. I'm going to give you a few seconds to try to identify the pathologies. If you can do it very quickly, that's fine. Otherwise, just determine that there is an asymmetry between the eyes and then what that asymmetry is and which eye is in trouble. And then if you can deal with the pathology, that would be great. So just a few more seconds to look at this. Which is about all you'll get from a patient anyway, and then we'll carry on with the webinar. Okay, we're moving on. This is the slide we'll be talking to. So for the history, this is a non-traumatic shoulder problem, and there is point pain on the right shoulder, and it sits about there, just anterior and inferior to the acromion, right that spot there. Now, what I've done here with the pathologies is looked at the, kept them fairly general, but looked at the main pathologies that you're going to work with. So what we've got here is AC joint pathology, tendinopathy, a labral tear, including a labral inclusion, arthropathies, arthritis, arthrosis, etc., traumatic arthritis and systemic, and also bursitis. Now, I've given some probability numbers for each one of these pathologies, and you can get these probability numbers sometimes from the prevalence of the condition if it's been published, but you're better off coming up with your own probabilities based on your experience in your clinic with your patient population. Now, the ones I've given here are not necessarily accurate by any means, but what I've done is I've tried to come up with the most likely probability for the most and least likely conditions. And I'm not arguing that these are accurate at all, so please don't hold them to me. They're examples of using it. Now, probabilities should be an important part of your diagnostic practice. At some point or another, if you're using likelihood ratios, sensitivity and specificity values for your tests and everything else, you need a pre and post-test probability so that you can apply Bayes' theorem to it and end up with how probable your final diagnosis is likely to be. But here we go. So AC joint pathology, I've given this a probability of about 15% as the pain isn't over the joint line. Tendinopathy and labral tearing, I've given about equal probability. And if you're wondering how you can get a labral tear without having trauma, they're degenerate labral tears and they come on with triggers rather than causes. So this thing has been degenerating for a while for whatever reason, possibly because of weakness of the rotator cuff allowing too much sliding of the humeral head and beating up on the labrum. So I've given these about equal probability because that's my experience with them. If anything, I would guess I see more degenerative labral tears than I do see tendinopathies. But they're also going hand in hand with a tendinopathy occurring because of overworking, trying to stabilize the humeral head. So it's not surprising to see these two things together. And the obvious tendinopathies here are supraspinatus and biceps, those tendons being in the right in front there. Along with labral tear goes a labral inclusion. So you get a tear in this and it blocks the range of motion. And I see these fairly commonly. They look nothing at all like a non-included labral tear. I've given arthropathy a much lower probability simply because of where the pain is. This pain is very pinpoint, and if you have an arthritis, then this tends to spread. This is where you get the typical deltoid pain rather than these points pain. So I don't think that's going to be very likely as the final diagnosis. Bursitis, I've given a higher probability because I think there's more chance of it than an arthropathy. But bursitis is you have to diagnose them by excluding everything else from it. But I've given that a 10% probability, twice as much as the arthropathy. So for the first three, these are your most probable, and it becomes a differential diagnosis at this point. Now, of course, you can ask more questions. The problem you've got is that most of those questions don't help very much. Probably the most useful piece of information you can find out is if they feel clicking and clunking in the joint, which would strongly indicate a labral tear. Unless the pain is occurring at the same time as they feel that clicking and clunking, it is not reasonable to assume that the torn labrum is actually the cause of the pain, as I say. What you could be doing is overworking the tendon, but it does tell you there's a labral tear. But simple clinking and clunking doesn't necessarily inculpate the labrum. So we go to our first test. What we're looking for is something as sensitive as we can find. Now, you're going to exclude the labrum by finding positives on this test. If you have a tendinopathy and you can palpate the entire length of the tendon and nowhere along it is it tender, more tender than the tendon on the opposite side, it is very, very reasonable to say that you don't have a tendinopathy. I can't imagine a tendinopathy not being tender. In fact, I've seen tendinopathies where the tendon itself is tender, but the patient has no symptoms from it other than that tenderness. For the AC joint, same thing. We can palpate the joint line and we can stress the joint, just get in there and scrunch it about and see if he can reproduce the pain. Now, those tests are going to be really quite sensitive here. If they're both negative, then by exclusion, you're left with a labral tear. But let's just see what happens if they're positive. If the AC joint is positive on palpation, we can then stress the AC joint for pain. Now, if I'll come back. Okay, so we can stress it for pain. We can go in and do biomechanical testing on it and see if that's also painful, and it'll also give us the motion dysfunction, so we can find out positives that way. If this is a tendinopathy and we have positive palpation, we can then do the contractile testing, either stretch it, contract it, under stretch, contract it in neutral. One of those tests should be positive if this is a tendinopathy. The problem with things like the empty can tests and so on is that they're not particularly specific, but we can argue that the contractile tests, when they work, are fairly specific, all else being equal. So there. With the labrum, if we find that the other two tests for palpation are negative, we can then work on the assumption this is a labral tear. And we can go in and basically do a load shift test and O'Brien's test. Now, the load shift test, if it's positive but not painful, tells you that there is a labral problem, but it doesn't say anything about that being the source of the pain. O'Brien's test, on the other hand, when it's positive, will tell you that the labrum is causing the pain. So ideally, what you'd like is both of those tests being positive. Now let's assume that all of this is ended up negative, and we come down to the right-hand side of the diagram, all the way underneath, and we come back to bursitis. So we've excluded those things, and what we're left with now is bursitis. And this is something you find fairly often. You find the contractile test, the tendon seems to be positive, the contractile tests are negative, and of course when you're palpating the tendon, you're palpating through the bursa. So it's likely that you have some inflammation of the bursa that's sensitive to palpation, but the tendon is okay. Okay, now, labral tears with inclusions. These act totally differently. They actually do block elevation, so you get limited range, near full range, but limited range. Often you can only pick this up though if you stabilize the scapula. So you stabilize the scapula by holding it up and not allowing it to descend, and then passively elevate the arm. And you'll find that elevation is limited by about 10 or 15 degrees compared to the other side. If you don't stabilize the scapula will move, and that bit of loss, 10 or 15 degrees, gets lost in the total range. And what you find now is you've got pain at the end of range, and the end of range on both sides looks similar. You just stabilize it, hold it up. It doesn't take a lot of stabilizing because you're not stressing anything, and just bring the arm up and you'll feel it come to a stop. And that may not be painful. Now, this strongly indicates a labral tear, for me anyway. Often when this is happening, if this is causing a lot of pain, you'll find that the contractile tests are positive as well. And you have you may well end up with generalized tenderness around the shoulder, probably due to segmental facilitation. So don't mess with the tendons. What you do is manipulate the shoulder and re-examine. And the way you manipulate this is the patient lays supine, you stand in between their arm and their body, and you apply the heel of your hand against the humeral head, and you push the humeral head outwards, so you're distracting it. And as under distraction, you thrust it downwards towards the floor, and then reassess the range of motion. And then, generally speaking, if you reassess for the positive contractile tests, they're all negative as well. It's a very, very satisfying technique when it works, and it usually does work, and the patient is extremely impressed. If everything's not working for you, you're thinking about an arthropathy, then just do range of motion testing. If this is an arthropathy, you will lose range, it will be painful at the ends of range. And if you've got a full range motion at the shoulder, or near full range of motion at the shoulder, then it tends to refute the hypothesis that this is an arthropathy. And as I say, a bursitis is what you've left with after you've discarded everything else. So I hope this is helpful to you. I think the slide's been up there long enough for you to take in the diagram. And I'll be seeing you in a couple of weeks. So let's just move on to the answer of the quiz, and then you can take off. Nice short one. So here's your answers. The top picture is a Horner syndrome. You can see the two eyes are asymmetrical. The first thing I notice with the top picture is that the right eye looks retracted, and this is an ophthalmos. However, it's not actually retracted, or it's believed that it's not retracted. What it is an optical illusion caused by the narrowed palpable fissure there, making it look further away, and the smaller pupil. The other thing you can notice on the left eye, the left iris looks darker than the right iris. Now, this isn't just a lightning effect. The pupil on the left is larger than the one on the right, and it gives you a darker spot. So these things become obvious. What's not obvious in this patient at all is the flushing of the face. And you certainly can't see any sweating or lack of it. So the eyes are really the soul to this condition. The lower one is, if I can get myself out of the way of the picture, is a left third nerve palsy. And again, that left eye is not as dramatic as the Horner syndrome, but it does look further back into the head for exactly the same reasons. And except now that left pupil is larger. You can see the ptosis here is obvious, although not severe, but it is obvious. And there is an asymmetry, slight asymmetry in the eyes. So there you go. We've talked about this before, but I thought I'd give it to you again. So next time, I may carry on with this format. It's a lot easier on me to do it this way. And I'm hoping that you like it as well. If I don't hear from you, I'm going to assume you do. All right, I always do that. If you don't say anything to me about not liking it, I assume you like it. If it's easier for me to do, so whatever works for me, really. So if you're not that keen on this format, let me know, and I'll see what I can do. But this is much easier for me to do, and I'm hoping it's as informative. Okay, stay safe, everybody, and I will talk to you again in a week or two. Bye.